All
Cool.
right, all you.
We'll kick it off. Well, hey guys, I think I saw a couple of people hop on that aren't regulars. My name's Cody Russell. I'm one of the primary care sports medicine fellows this year. We are talking about marathon medicine because this weekend is the Cleveland Marathon. So hopefully we see you there. I think my goals for this lecture, I tried to read as much as I could from like textbook and lit review standpoint, and I tried to keep it as clinical as possible because I figured this would be kind of nice to go through like a couple days before we actually do it. So most of this is kind of clinical stuff, and then towards the end, if we have some time, I'll try to go through some of the like ACSM position statements more for kind of board review type stuff. But maybe we'll run out of time and we won't have to get into that if you guys are lucky. But we'll get into it. So I think as some quick background. By no mean do I mean like pretend to be some sort of marathon expert. I have covered a couple big events. I used to help with the Nashville Marathon a lot, which is a very big marathon. They have like 25,000 people per year. And I've helped with the Florida Ironman, I think just once. And I think they have like 10,000 people and it's like ridiculously hot there. So that's kind of my background. And then I'm emergency medicine trained. So I feel like we see a lot of this stuff that gets transferred to the ER. So I feel like I'm like moderately familiar, but by no means am pretending to like I wrote 7 textbooks on this. A lot of this is just kind of from the background stuff that I've read. Um, so like quick table of contents, we'll go through some clinical stuff. A lot of it's on collapse because I figured we should talk about the big scary stuff, and then nobody really cares about, blisters and things like that. Then we'll go through some of the textbook stuff, and then if we have some time, I do have trivia at the end of it. We'll do one of those Kahoot games, and winner, I'll think of what the prize is, but whoever wins, I will give something to. All right, so we'll get into the clinical stuff. I think to address kind of the elephant in the room, like I think obviously the biggest concern during marathons is cardiac arrest. This does happen, unfortunately, even at the Cleveland Marathon in 2019. Unfortunately, there was a cardiac arrest that was not able to be resuscitated. So just I think we'll kind of get this out of the way early. But I think it's important to talk about. And I think some of my sources, JAMA and New England Journal of Medicine, I'm not sure if you guys have heard of those. They're pretty small journals. Have both published some research on this. And I tried to kind of boil it down as much as I could. I think from like a statistics standpoint, to no surprise, the incidence is like much higher in marathons than in half marathons. Um, I think the most accurate stat I could see is like 1 per 100,000. So like if you think about there's 10,000 people in the Cleveland Marathon, this isn't how stats works, I know, but like, 1 every 10 years, there's statistically going to be a cardiac arrest. So it's like kind of rare, but also really not that rare. It's much more common in males. I think red font here, red font is like, please remember this forever. This typically happens at the end of a race, like the last couple miles. So I think that's important to note, and we'll go through that a little bit more in the lecture. They've found that stimulants, I believe when they actually did the autopsy for that young female that had a cardiac arrest, there were some stimulants that were related to the cardiac arrest. They thought first timers are higher likelihood, and then age over 40. I think the average age was 42. I think that like two main takeaways I took from all these articles, I don't think are like rapid developments and resuscitation, but it's immediate CPR and then trying to defibrillate people basically as fast as you possibly can. Those are the two things that are known to improve outcomes. Nothing else has been shown to improve outcomes. So I think focus on the easy stuff, immediate CPR, and try to defibrillate them as fast as you can if it's a shockable rhythm, obviously. Um, and then they made, I think, some like encouraging comments. There's been a 50% reduction in deaths during marathons and sort of 2 time periods they looked at. And they contributed that to people creating emergency action plans and then like people being much more comfortable with AED use. Um, so to just talk about like really bad situations and medical events, I feel like sometimes like nobody wants to talk about it and we just like pretend like it'll never happen. And then it does happen. And the only thing worse than like thinking about this or talking about this is not being prepared for something to happen. So I think wherever we all end up next year, I really encourage you, like when you show up to a football game or an event, to just like go ahead and talk through like if shit really hits the fan, what are we going to do? I think it's much more better to be prepared if it happens than to have it happen and then be unprepared. I think it's important to assign roles. So, if you're with a EMT and a nurse and two residents and a medical student and a fellow and an attending. There can be a lot of people. And I think kind of discussing, hey, if this happens, who's going to do what before it happens, things can go so much smoother. I think practice is important. When I was in residency, we got to spend some time at the like Mayo Clinic Sim Center. They have this like big, I tried to find a photo of it, but I couldn't find it. They have this big like quote on their wall that's basically like, we do all these things in life and we like practice them and simulate them, but for like patient care where we're doing things on real humans, like it's not something we typically do. And that's really resonated with me. Like you practice like free throws, for basketball, but we don't, do much simulation for these like pretty high intense, you know, low occurrence things. And I think it's important if you can, like that's why we've been doing EAP practice more. I think it's important to kind of practice this because you can iron out some wrinkles. And then I think last thing to talk about when bad things happen like this is leadership skills. I think the calmer and like more organized a situation, the better it's going to go. And at the end of the day, you want your team to work well together. When everyone like freaks out or you're yelling at other people or things escalate, it just really kind of spirals out of control. So I would just encourage everyone to try to kind of keep like a calm presence and everything will work out much, much better. Um, as some comedic relief, because I know it's not fun to talk about cardiac arrest at 8:08 in the morning. This is what I would call the evolution of a fellow. You can see on the right over there, that's Boswell. And I just really want to give Kevin Killian some mad progress that he's made this year. He's so close to being there. We're really proud of you, Kevin. So to go through, I just wanted to do a question before we go into some of the kind of like clinical breakdown. Can I get a volunteer just to go through this and read it and see if you would be comfortable giving it your best shot? Bonus points if there's a like med student or resident out there. No takers?
I'll help you out after that lovely diagram. Which of the following is most likely the cause of his symptoms? Exertional heat stroke, exercise-associated hyponatremia, cardiac arrhythmia, exercise-associated collapse, or acute MI. So it's a 29-year-old recreational runner who collapsed at the finish line on a warm day, conscious, but oh, your beautiful face is in the way, but lightheaded, pale, and diaphoretic. Vital signs, he's hypotensive, tachycardic, respiratory rate's normal, and his temp is under 40 degrees Celsius, and no chest pain or shortness of breath. Drank water throughout the race, but denies any electrolyte supplementation. Physical exam is otherwise unremarkable. After lying supine with legs elevated, his symptoms improve within minutes. So it's not an acute MI, it's not a cardiac arrhythmia, and it's not exertional heat stroke. Is it exercise-associated hyponatremia or exercise-associated collapse? I mean, I'm sure he's probably a little hyponatremic, but I'm going to go with exercise-associated collapse.
Man, he's good, guys. Nailed it. I also love I love how you went through the question and the answer choices first, just so you didn't waste your time reading like 17 sentences. He's a beast. That is correct. And I thought this was a good like clinical vignette because like basically the answer choices are what we're going to be going through for the next 5 or 10 minutes. And it's like a Venn diagram. There's a little bit of overlap of all of them. Like Kevin's totally correct. He probably is a little bit hyponatremic. Some of these kind of overlap, and that's going to be what we're going through soon. So, um, exercise associated collapse. I figured it was good to start with this for marathon coverage because this is other than like blisters and cramps. This is probably going to be the thing that we see the most this weekend. It's super common. The research shows it's about 1 to 2% of all finishers. I saw one research that said during an Ironman, it was 27% of finishers. That was not my Ironman experience, but that's pretty crazy. And it's somewhere between like 59 to 85% of all medical tent visits. So I will be shocked if we don't see this weekend. And just to sort of go through what it is, because I was kind of like exercise associated collapse. That seems like a very vague, broad term that I don't love. It reminds me of like brewy for peds. It's like, yeah, it's just, just something bad happens and it goes away. Um, but there is some physiology behind this. Essentially, you're like doing, high level activity for a long period of time, and then you like suddenly stop or slow your pace. And this is a blood pooling issue. It's a issue where your hemodynamics change like acutely. So I think a couple takeaways. I tried to find a definition because it's like if you don't know what the definition is, you don't even know what you're talking about. And I found this definition and I really like it. So exercise-associated collapse is the inability to walk, stand unaided after vigorous endurance exercise with associated lightheadedness and syncope. And I think the key word for me there is after. This is not like during the middle of a marathon. This is not, 30 minutes once you've been sitting. This is like immediately after you finish exercising. And once again, it's a blood pooling issue. And the treatments to elevate your legs essentially and kind of give some people's time to body to sort of equilibrium, like I guess equal. We'll just go with equilibrium for now. I think when you're evaluating these people, like obviously assessing if they're responsive or not is a good place to start. And then we kind of talked about treatment. Thank you for Kevin for modeling for us over there on the right, the Trendelenburg position. Some of these get interesting where like, let's say you have a collapse at the finish line and you're like 10, 15 minutes into this and they're not really doing great. I really think you need to start considering that maybe this isn't exercise associated collapse. So I think you need to start like I would get vitals pretty early on these people if they're not immediately coming to. I think checking a glucose or checking a rectal temp are pretty warranted. And I think just verbalizing these with a patient, you can know kind of quick like how serious this is. When you start talking about like doing finger sticks or rectal temps and people look at you very lucidly and they're like, yeah, I'd rather not. There's a good chance they're not like severely hyperthermic versus if they're in no man's land and can't really have a logical conversation with you, it probably is worth considering checking some of these things. To talk about dispo, because I feel like it's always hard for me when people come in to be evaluated for something pretty serious. Like, when do you feel comfortable for them like going home? I think some of the research that I read is, I mean, obviously when they return to normal, but there's a recommendation to have like a family member or friend with them just so they could monitor them. I think that would make me feel a lot more comfortable. So don't feel like you have to like dispo these people by themselves to like walk 7 miles to their car. Having them be with someone I think is very reasonable. Some of the criteria was make sure they're ambulatory, make sure they're normal thermic, make sure they have normal vitals, and make sure they're not altered. I think those are all kind of understood. And then, like, what do you do if someone's not improving? I think one thing I've learned to do in the ER is to sort of like set these like clinical lines in the sand and to kind of verbalize it with the team. So, I mean, dealer's choice, but whether you say, hey guys, like in 15 more minutes, if this person's not better, like we're checking a rectal temp and a glucose and we're making sure there's nothing else going on. I'm not saying do it at 15 minutes. I'm just saying I think there's always this wishy-washy of like, oh, are they better? Are they not? I think it's okay to just set a line and say, hey, at some point in time, we're going to make sure we're not missing something else. It could be right up front or it could be at a set time period. But I think that helps some of that like ebb and flow wishy-washiness to get through some of these gray area situations. For all the people that'll probably half paying attention, like please, this is the one thing I want you to take away from this slide. When you're thinking about collapse, I think it's good to think about it sort of almost like the geography of the race. So like most bad things don't happen at the beginning or middle of a race. Like miles 0 to 18 of a marathon, people are probably cruising. Like, look how happy she is. She has double peace signs up. That is about as happy as you can get. Where really bad stuff happens is those last few miles of a race. At least that's what the research shows, that most big like cardiac collapse events are going to be in the last couple miles of a race. And then after a race, when people like stop immediately after the finish line and then collapse, I'm not saying don't worry about that. I'm just saying that's where you're going to see exercise associated collapse. It's not going to be at like mile 16, where people have been jogging. And then like I hate to keep thinking of this as brewy, but to me, like it kind of is a brewy. And I say that because exercise associated collapse, it like when you're having some other things going on, it's not exercise associated collapse. So if it happens during the middle of a race, or you're not recovering, or you have crazy abnormal vitals, or your glucose is like 30, or your core temp is 105, or their sodium's like 110, it's not really exercise associated collapse. That's something else terrible going on. So I think always think about those bad things in the back of your head rather than just being like, oh, like it was kind of at the finish line, so I'm sure they're fine. I think like our job is to assess the scary things first and not kind of brush it off. Category 2, heat-related illness. I looked at the temperature this weekend. Obviously, you'll have to like see what the wet bulb is, but we'll probably be okay. But I think this is a big concern in very, very long events. Heat stroke is very life-threatening. Like the research shows there's about a 10% fatality rate if you don't do anything about it. And then obviously risk increases when temperatures get above 80, but more specifically, the formula for it has a very high factor for humidity. So humidity is a very, very big factor. You can have temps of like, I mean, 80 doesn't really sound that hot to me, but when you're getting into like high 70s, 80, and it's very humid, it can be a pretty nasty environment to run in for a couple hours. So I found this, like, I like to think about things of a spectrum because I feel like we pretend like medicine is black and white, but it's really not. Um, and I think a better example of it is really like this. I think heat illness is sort of like this. Like, if you're on this slippery slope and you don't intervene, it is going to get worse. So as you get into like heat injury or heat stroke, you just kind of spiral out of control. You lose your ability. Your body literally loses its ability to cool itself. So like at some point the train gets going too fast and the wheels are coming off unless you get some intervention. And I think our job is to kind of hacha, stop that. And I think we all know the treatment for this, but it's an ice bath. And I think if there's a second point you can take away from this, like cool at the scene. Do not transport patients that you feel like are having heat stroke 25 minutes to an ER. Like cool at the scene. That's the big takeaway from the position statement from ACSM. I think that's just good medicine. So your goal is to basically as rapidly as you can drop temperatures from whatever it is, 104, 106 to 101 within 30 minutes. So if you have 30-minute transport time, you're completely missing that window and they're just going to get worse and worse. So our goal is to kind of as quickly as we can stop that cycle and get them in a nice bath. 104, I'm a visual learner, so this is for you guys. 104 is like technically the core temp to be considered for heat stroke. I mean, I think if you're at like 103.9 and someone is altered out of that mind, like out of their mind, I don't think I'd be like, oh, this is heat illness. Like that's heat stroke. But for test question numbers, 104 is the magic number. And then just some kind of quick temperatures to go through again. So 104 is the magic number for patients plus, altered mental status. The ice bath recommendation, kind of surprised it was this broad, but it says 35 to 59, which is a really big gap. They said maybe somewhere in the middle might make patients more comfortable, but I actually feel like I kind of like the colder ones because a lot of people at the end of a marathon are like, hey, can I hop in? And if it's super duper cold, like maybe they won't want to hop in as much, and you're also cooling patients quicker. So I think if you can aim for the bottom end, it's only going to warm up. I would not start your day at 59 because your water is going to get way too warm and be less effective. And then the target temperature that you want to pull people out of the ice tub is 101. I think I saw 101 to 102 as like the recommended range. Then once again, I can't say that it's enough. Please cool at the scene. To go through some equipment, like bonus points, if you have a temperature probe that can stay in, it's not fun to keep doing this over and over, but most people are not. If you don't have that, I think it's nice to just set a timer, like literally set a timer on your phone so that you don't forget. This is, hey, I'm gonna like check them or check their temp in 5 minutes. I'm sure you're staying there with them, but it's just a good reminder to the group of like, hey, at this point in time, we're gonna like reevaluate them objectively. There's no research whatsoever that like Tylenol is going to help this. That is not the problem. There is some research that IV fluids can actually make a pretty big difference. And that's because the temperature difference between like, room air, IV fluids and 104 is actually quite big. Versus the temperature difference in like hypothermic patients. The reason we don't really give them warm fluids is that temperature gap isn't as much, but that is the case when patients get very hyperthermic. And then in case anyone wants to buy this really cool Disney fan over here, another thing that you can do if you don't have a fancy ice bath is just evaporative cooling. So you can spritz people. Everyone pretty much has water. You can spritz people. And then if you don't have a fan, you can get some sort of cardboard box and fan the crap out of them. But you're just trying to evaporate, you can do basically evaporative cooling for them. Spritz them, fan them. It's going to cool them off some. It's not going to be as good as ice. There is like the body bag trick where you fill it up with ice, but I feel like not many people walk around with a body bag. So maybe the evaporative cooling would be a better thing. And then I think last time I'll say this, please cool at the scene. I don't know. I feel like I've seen this at a couple events. Anaphylaxis is not uncommon. Oftentimes people have an EpiPen and they're like holding it, and I don't know why, but they won't use it. So if you see someone who collapses who's like holding an EpiPen, maybe go ahead and use their EpiPen if it seems like anaphylaxis. I think everyone's always like wishy-washy on like when do we use an EpiPen. I think the research shows there's actually three indications. So One, if there's any sort of like acute, let's just call it hives, but they're calling it skin illness, mucosa illness plus distress. So something like hypotension, or they just collapsed, or they're in respiratory distress, you can use the EpiPen. Category two is if you have two organ systems and a likely exposure, you can use the EpiPen. And then category three, I'm embarrassed to say this, but I didn't know that it was like technically known allergen. But if you have hypotension plus a known allergen, that's category three and something you can use an EpiPen for. For all those people that haven't been paying attention, please pay attention again now. People all the time EpiPen themselves right in the thumb. So there's like two things you should know about EpiPens if you have to use them. One, there's two colors on like, the brand name. Blue goes towards the sky. The orange one as like safety, color is the one that goes towards the skin. And I always think of it like a caveman. Like if you actually look at this photo, you see how that guy's holding it. His thumb is not at the top, like as if it gives you some sort of extra power boost, like a clicky pin. That's not how you hold them. If you hold it like a caveman, like an ice pick, you can't poke yourself. So take the blue cap off, and then don't worry about putting it right on your thumb because that's a terrible idea. So the blue safety cap is what you're going to remove that kind of exposes everything. Hypoglycemia, I won't spend too much time on this, but I feel like it is a, somewhat common reason for people to collapse or be altered. It's like the world's easiest test. A finger stick poke takes like 3 seconds. The research on treatment is like if people are awake to try to give them oral glucose, and if they're altered out of their mind, obviously you have to give them something else. I doubt we're getting like super rapid IVs there, so you can always consider glucagon. I actually didn't ask Dr. Luke if we have that, but there's EMS there, but your choices are really, D50 or glucagon if people are, not able to take oral glucose. Hyponatremia, I feel like this is probably more of a test question than something we'll see, but Dr. Luke did say actually that there is an ISTAT there and there is hypertonic saline. So this is actually on the radar for something you could treat this weekend. So the issue with hyponatremia is people can start seizing and then obviously have like hypoxic issues and have very bad outcomes from that. So some of the risk factors that ACSM went through, if you're like actually gaining weight during a race, they said greater than 3 liters of fluid, this puts you at bigger risk for going, into severe hyponatremia. Prolonged races, if you have a really low BMI, female gender, extreme temperatures, or NSAID use are all risk factors. I think the EM literature for us is, to treatment recommendations. I won't say criteria, but recommendations. If you're less than 110 or if you're less than 120 with symptoms, so like seizing or you're altered, those are two like sort of general guidelines on when you could consider treating. To get into some of the textbook stuff a little bit, 825, we're doing all right. Environmental illness. Wet bulb globe temps, I think, are something good to know about that I could see being a fair game question. This is something that takes in a lot more than just temperature. Like when you open your iPhone and you look at weather, you might see 70, but the wet bulb globe temp could be like 82. And that's because it's factoring things like humidity, like radiant heat from the sun or from, a huge metal building that you're around, wind speed, and then solar radiation and sort of like what the cloud cover is. So it's a much better example of like heat related stress that you're feeling versus just temperature. And that's why when we're going off of like safety and events, we're always using the wet bulb, not temperature. You don't cancel events off of temperature. You do it off of the wet bulb globe temp. I think I have another slide about sort of consideration for canceling. So this is a chart I saw that's sort of a mix of ACSM. They have these, 5 colored flag recommendations. And then categories, I had to look this up. Categories is sort of like a geographic region. So you can find your region and then find the wet bulb globe temp that sort of generally recommend you don't consider doing things. I think if you want to remember a magic number, 82 degrees Fahrenheit is the number I've seen a couple places. There's no like technical formal cutoff, but I think the IOC uses 82. And I found a couple examples of when this came into play. The most recent one I think was 2019. It was the Twin Cities Marathon. The predicted wet bulb globe temp for their marathon that day was supposed to get up to 82. So they actually did cancel the marathon. Everyone was upset. They're like, it's 72 out. But the wet bulb globe temp was 82 for that day, and they felt like it was safest to cancel. And then in 2012, sort of same thing. The forecast was greater than 82 in the Boston Marathon. did not cancel the race. They just basically like strongly advise people to not run it. That's probably because it's like a pretty elite event. But yeah, just I think knowing some of these numbers is good. Um, there's a section about planning for marathons. I think a couple points to take away, like 18 pages of reading that I did. In case anyone comes into like planning a 5K or a marathon or something, I think coordinating with EMS is a very important thing to start with, because if anything terrible happens, like, what are you going to do? You need to have a plan for that. So I think starting with EMS really early and getting them involved is appropriate. It's always so sad, but they recommended really at any point, if you're planning a mass event right now, you need to plan for sort of like terrorism events and what your plan is for mass casualty events. There's equipment considerations like medical tents and how you're going to transport patients. And one thing I hadn't thought about is medical records. So if you're starting an event next year, you have to figure out if you're going to do paper charts and what forms you're going to do and how you document it and how you keep those records. But there's a lot of nuances that I think you have to think about: staffing, and then sort of creating an emergency action plan. A couple things that we probably won't see, but I think are board relevant to sort of marathon medicine, is rhabdo. We talked about this a little bit earlier in the year. If someone comes up and is like cramping for 30 seconds and then it goes away, that's not rhabdo, that's a muscle cramp. But rhabdo is this like persistent deep pain that's going on for hours. Sometimes you'll get dark urine. You typically get systemic symptoms like nausea and you're just feeling terrible. I think two things for us to take away. Everyone knows about hydration, but I think if you have someone you're concerned about rhabdo, you have to mention, like, don't take NSAIDs for, your like terrible muscle pain, because that's not an unreasonable thing to do, right? If you're hurting all over for the flu, we tell people like, hey, take Tylenol, ibuprofen. I think you need to specifically mention, do not take, NSAIDs or ibuprofen during this time period. And then I think a good board question, at least that came up on my boards that may not be on the sports medicine ones, but like, if you get a dipstick, there might be no RBCs because it's not actually blood, but it's dark urine, and it'll be, hemoglobin or myoglobin positive. And then I don't know how specific they'll get, but some hospitalization criteria. I think we talked about this a couple months back, but if you have rhabdo, so you like symptoms plus some of these criteria were recommended for being like kind of sketch. So a CK over 20,000. If you have myoglobin in your urine, you're having renal dysfunction, acute kidney injury, or a sickle cell history, just because the chances of that escalating are significantly higher. I don't think we'll see any hypothermia, but it is relevant to marathon medicine. I think there's charts. I'm not going to like go through this or make you memorize it. I think that the number to remember is like 35 degrees C, which is like, technically 95 Fahrenheit. Frostbite, once again, I don't think we'll see this. I'm not going to go through the levels because it's boring, but there are levels you can look up later. I think two takeaways for me is like, don't rewarm until you're completely out of the cold. You do more damage than good if you rewarm and then immediately put them out in a cold exposure and you like double frostbite. That's going to be much worse than just actually keep them in frostbite territory, getting them out of the bad situation, than fixing it. So if you're in some sort of remote ultra marathon, Kevin Chang, I'm talking specifically to you. Um, Try to get people to a place where they're good from the cold exposure before you start rewarming. And the way to do it is warm water. It's not hot water. It's not cold water. It's like warm, sort of like body temperature water is how I remember it. Because I'm always like, how warm is warm? And it's basically like hot tub water. Like 98 to 102 is like hot tub territory. So you don't want it like scalding, because it'll do it quicker. It's not like an ice bath where you're trying to cool them as quick as possible. This tissue is damaged, so you're trying to be a little bit more gentle. Altitude. I had to look this up this morning. The Cleveland Marathon is at like 570 feet of altitude, so hopefully we'll be okay. I tried to break this down into like the three things that I think questions are always about, that I was always like, crap, which one's which? So there's three, I think, common things that we'll get asked about for like altitude illness. One is acute mountain sickness. That's anytime people go up to, reasonable elevations and start having systemic symptoms. And I think the takeaway is like, you feel bad here. You feel bad, but you're not having like, end organ dysfunction. You can prophylactically treat these people with acetazolamide, especially if they've like, every time I go to Denver, this happens. That's something you can consider for athletes. And then the two like bad things are below: HAPE, high altitude pulmonary edema, and then cerebral edema, HACE. These have end organ dysfunction. So that's how I remember them being different. Like acute mountain sickness, you feel bad. And these two, you feel terrible and you start having like pretty scary stuff. So for the pulmonary stuff, you might start getting crackles or hypoxia or respiratory distress. And then for the cerebral edema, I think these people in real life and in board questions are going to be ataxic, lethargic, altered. They're going to give you something where this person is starting to have some some end organ dysfunction. And the treatment for this, like 99% of this treatment is just descent, rapid descent. If you can't descent, it's like hyperbaric treatment, but it's going to be descent. There's some medications that may be helpful, like nifedipine or acetazolamide or steroids, but I feel like the real treatment here is descent. Um, Before we get into our Quizlet, does anyone have any questions for me or any comments just about sort of the clinical aspect of stuff that I can clarify, or things you've seen that you want to talk about?
Just for the fellows, on the test, sometimes the difference between chilblains and frostbite will come up, so know that.
It's a good one.
And then a lot of times they like to ask about like what's the first step and what's the next step. And so specifically for like altitude medicine, like the first step is descent, but then they might ask about like the nifedipine or acetazolamide, like next step type of stuff.
Practical stuff for race, management. You will see heat illness. You will see heat stroke. When I was doing the marathon stuff, I was called Dr. Rectal. If you're not doing a rectal temperature, it doesn't matter. It's not true. Like I've had people come in that are just sort of, actually we had the winner of the marathon come in. This is a couple years ago, and it was really pretty cold out. And so we were like, assumed that she was hyponatremia or hypothermic. So we're like wrapping her with a towel and all that, like a metallic blanket. And she was actually overheated, which was interesting. And then the other thing is low sodium, you will see, it's a real deal. And it's very common in the people that run slower, the less experienced people that just drink water and they don't take any carbs or any electrolytes during the race. You'll see them with kind of swollen, doughy hands and kind of a lot of people are going to be somewhat out of it because they're not as well trained, whatnot. So the iStat is super helpful before you just load them up with fluids. The bummer is when you do an iStat, a lot of times they just throw an IV in and then they hang fluids and you're like, well, that may not be the treatment. And certainly PO hydration is better than IV hydration. And then the last thing is rhabdo, a lot of times not a lot of times, but you got to be mindful of the people that are kind of overheated, but not in heat stroke territory that go on to have, muscle breakdown and rhabdo. So anyone that comes in the tent, I think it's worthwhile saying to them, like, don't take a ton of ibuprofen the next couple of days, make sure you hydrate, and whatnot. And then just one comment for you, Cody, it's fun to listen to you talk, but you must have said 5 times, I had to look this up today, or I had to look this up, I didn't know. Just don't say that. You're supposed to be the expert when you're talking. We'll just think you're super smart if you know what the elevation is in Rocky River or wherever we live.
569 feet. Cool. Well, thank you all. There is some trivia, so don't go anywhere because we still have a little bit of time. But
wait, I was going to add one other thing that's practical.
Yeah.
If for cooling, body bags obviously aren't something that people have, but tarps are. So a lot of people talk about using a tarp and doing a burrito method where you load the tarp with ice and then burrito the person in. So that's like a little bit of a more practical thing people can do when you don't have the big giant Rubbermaid tubs. And then you just have to be mindful to turn over the ice frequently because it doesn't take long for it to melt in that situation.
All right. Here's my little ones. I feel like I've been rather distracted this year, so part of this is thanking you all, but thanks for putting up with me this year. It's been an interesting ride. All right, let's do some trivia because I feel like some of these ACSM position statements were a little bit dry to put into slides. So let's see if I can get this out of the way. All right, if you want to pull out your phone, if you want to participate in this, if you scan this QR code and enter your nickname, you can enter your real name, but everyone's going to know who it is. So scan this QR code and then enter some sort of ridiculous nickname, and we will get things underway. Let's see where we're at. Well, there's at least 3 fellows, so I need at least one more.
Honestly, I can't figure out how to do it. I'm not a fellow, but I don't know how to do it.
If you open your camera and just put it over that, there'll be a yellow thing that shows
Oh,
up.
but see, I'm on my phone.
Gotcha.
Yeah, me too.
So I
I'm on
gave
my
up. I
phone.
was like, I don't know.
That's fine. We'll have a 2-person showdown. I was like, hey, Dr. Cup's on. All right, we'll start there. I'll let everyone kind of follow along virtually. You can still see my screen, is that correct?
I have discussed this with the
Yes.
fellows. One of you young people needs to develop an app where you can click on the stupid QR code on your phone and it makes it the same as scanning it. I don't know why one of you hasn't fixed it
Yeah.
yet.
And as a heads up, I trialed this. Sorry, I'm an expert. I trialed this 1 year ago. I made sure this worked last night. It gets a little bit confusing because you're going to want to click it on your screen, but it's on your phone. The answer choice is on your phone. Okay. But I think this will be a good way to go through some of this content. It's kind of weird doing it on Zoom. All right, let's begin. Exercise-associated collapse is most likely to occur when, gotta move the Zoom thing. Dang, y'all are quick. Look at y'all. Y'all are good. All right, we started off easy. Let's see who got it quickest. Sean Cobb taking the lead. The Jack Russell was just savage, guys. What factor below has greatest effect on wet bulb globe temperature? I like how quickly you went with it, though, whoever chose dry temperature. I respect the rapid fire. It is humidity in the formula. The wet temperature has a greater has a more heavily weighted weight ratio than the other ones. What is the target temperature to cool heat illness patient before removing from the
Mandy, you're not muted, just so you know.
Nice. It's 101.
Here, Eddie. Eddie's a good boy, though.
Thank you, Cody,
He's
for
such a
making
good boy.
a rally. All right. Which factor is suggestive of severe rhabdomyolysis needing hospitalization? All right, that is correct. Onset within greater than 12 hours after event. I just made that up to try to make something that sounded real. I don't think there's any specific timeline that's been shown to like be, whether it happens immediately following an event or a day later. I don't think there's one that has been shown to like necessarily require hospitalization more than the other. All right, crushing it. It's not tetanus. I mean, that might be another thing you can do if there's open wounds, but that's not the initial treatment, even though every trauma surgeon thinks it is.
And everybody needs their vaccine, so just do it anyway, just for fun.
Which of the following is true in regards to carbohydrate consumption and competition? No answers. All right. We really just fizzled out there. I like it. The correct answer is 30 to 60 grams of carbs per hour. That's from the ACSM position statement. I think I put this in my lecture, but the other one in regards to sort of marathons that's relevant was for hydration. Their recommendation was to try to lose less than 2% of your body weight. And that's just because everybody's sort of body habitus and, fluid status and, how quickly they're losing water and the environment conditions are so different that it's hard to be like, drink 4 milliliters per 20 minutes. It's just sort of about trying to keep your body weight, not overdo it, not underdo it.
This is one of the questions that they like a lot. And also, Cody, tell them what the correct amount of time it is for participation in sport that you want to do carbohydrates instead of just water, because that's another one.
I think it was, oh shoot, was this water or carbs? I think it was 1 hour.
1 hour. So if
yeah.
you're participating for more than an hour, you want to use carbs in addition to water. And the 30 to 60 per hour is correct. Both of those questions come up a decent amount on the test. And with families, so like kids who have 45-minute soccer practice don't need 300 calories of Gatorade.
Yeah, that's fair. All right. I think there is one more, but we all know this. Sorry. It's it's trying to get someone into a cold water tub as fast as you can. And I think I guess my two big takeaways are like, where do people collapse? And please get people into a cold tub as fast as you can. Any other feedback, questions, thoughts, post quiz? Thank you, Cody, for taking the win, whoever that was. I really appreciate it.
Great overview.
All right. Well, if anyone has any feedback, like Sue said, I don't know if we're doing the same thing. Feel free to email it to me if it's too harsh to say on here. But thank you all for listening in and looking forward to seeing some of you guys this weekend.
Good luck
Yep,
this
enjoy.
weekend. Can you make sure you send me a copy of your talk?
Yeah, sure. We'll do.
Awesome. Thanks.
All right.
Great.
See you
Thanks,
guys.
Cody.
Good one.